In a research paper we presented at this meeting, we start to explore those mechanisms that lead to resistance of venetoclax therapy. What we're trying to do is trying to dissect the molecular mechanisms by which venetoclax may lose its effectiveness. Venetoclax, of course, is not an FDA-approved drug for the treatment of myeloma, but we know both from preclinical studies as well as clinical studies that it seems to be highly effective for patients who have a more lymphoid type biology for their myeloma. These are predominantly patients with a translocation 11-14. Now, there may be other patients that benefit from this, and we've seen that with patients who have high BCL2 expression. The group from Emory has published a flow cytometry assay that looks at surface lymphoid markers. So in general, there's a group of myeloma patients that have a little bit of a less differentiated profile, what I'm calling now a younger form of multiple myeloma. And the results for this population are really astounding. Dr. Kumar presented the Bellini study, the final analysis for overall survival, which is a study which was fraught with problems, but the main one being that it accrued patients who were not enriched for this category of 11-14 or BCL2 expression. Based on that data on the preclinical, we have been using venetoclax off-label. First, we did so in combination with dexamethasone with very good responses. But then after a year, 2 or 3 years, some of the patients started experiencing evidence of relapse, so they were progressing. So what we did is we collected samples before and after and are starting to study the mechanisms, particularly molecular analysis of the signaling pathways that may indicate that the cells might shift lane. As a reminder for the group, the majority of myeloma for anti-apoptotic signaling goes through MCL-1. That's about 80% of patients. But it's that 20% that goes to the BCL2, which represents the target for venetoclax. So I invite people to see our data. Our poster is pretty preliminary, but we hope will give us a better understanding, not only of why this happens, but also how to overcome this through perhaps combinatorial approaches into the future. Now, we've seen a plethora of studies come out using venetoclax in combination with bortezomib, like I said in Bellini, with carfilzomib, but perhaps most excitingly, there's a beautiful paper that was published by Dr. Nisar Baylis just a couple of months in JCO where they combined daratumumab, venetoclax, and dexamethasone with just simply outstanding results.